and then we can get going here. So, cool. Everybody see that okay? Okay, great. So, I did, Marianne and Whitney and others who are thinking about this curriculum wanted me to talk to you a little bit about sort of ambulatory management of COPD. And the truth is that we can't cover all aspects of COPD today. I really just want to cover some basic tenets that I want you to sort of think about when you're managing your patients in clinic. Let's see. Okay. Can't, like I said, can't cover everything, but we will try to cover most things. Oh, come on, what's going on? No. COPD, and the reason it's so important, is actually one of the major preventable causes of death from a chronic disease in the world. But it's also really important to know that a disproportionate burden of COPD occurs to people of low socioeconomic status. Due to all sorts of differences in health behaviors, social and structural exposures, environmental exposures, socio-political factors, all sorts of things. And it's interesting to see this geographic disparities occur as well. And so here you see the disparities in hospitalization rates for Medicare beneficiaries hospitalized for COPD, and we sit, right up here in the Pacific Northwest, and we have some of the lowest hospitalization rates for COPD in the country, even though, of course, you see a lot of them and you're like, oh my gosh, there's like a ton of patients with COPD. But compared to, other parts of the country in here that just see, and some people kind of refer to this as, the tobacco belt, or there's a lot of industrialized work there where people are exposed to various things. So there's a lot of geographic disparities, but there's also income disparities and education status. And here on this side, what you see on the y-axis is your FEV1, your percent predicted FEV1. And across the x-axis, you see income, low, medium, and high. And what is that, the z-axis? Education, low, medium, and high. And this is going to make sense to you, but of course, and this is even with people with COPD, people who have higher educational attainment and higher income have higher FEV1s than people with low income and lower educational attainment. And it also applies to those at risk for COPD exacerbations, where the flip of this chart now is true, where those lower income, lower education have higher risk of COPD exacerbations. And so, probably not a big surprise to you, but I think it's important to think about these things when taking care of patients with COPD. So let's get back to a case to think about, and this is your first patient this afternoon in clinic. He's a 64-year-old man, and he comes in to establish primary care with you because he heard you're new to the system and he wants you to take care of him. He smoked a pack a day for 45 years, He has a history of mild hypertension. He's on thiazide, aspirin. Another doctor once mentioned that he might have emphysema. His review of systems is in fact positive for exertional dyspnea. He walks slower than other people on the level. He has to stop for breath every 2 to 4 blocks. His physical exam is pretty normal, except for mildly decreased breath sounds and rare bibasilar crackles. His SAT is 95% on room air. So that's the patient who comes into your clinic. And I want to know if you think he has COPD. Oh, look at that. A poll. I love it. Totally forgot we were doing this. Come on, you guys. This is a lecture on COPD. Don't you think he has COPD? But everybody is exactly correct. And that we just don't have enough information. Whoops, what happened? Okay, how do I take the poll down? There we go. So it's really hard to tell, right? What else could he have? He's 64 years old. He's got hypertension. He smokes. He's got some crackles in his bases. He could, what, Matt?
Heart failure?
He could have heart failure. He totally could have early heart failure. Someone throw out just another idea what he could have. Crackles in his lungs, 64-year-old man.
Pneumonia, alpha-1 antitrypsin.
Okay, good. He could have pneumonia. I didn't say that he was febrile or anything, but he totally could. Alpha-1 antitrypsin would be a form of COPD, totally.
Asthma?
Asthma, yep, he could. Less likely to give him crackles, but totally could. Oh, I don't know why my, okay. This is absolutely one of the major points from today. Maybe we'll just take a lunch break after this. Dysmea, you're going to see this over and over again. People have shortness of breath, they've smoked, and there's a chart diagnosis of COPD. But they could have any other, many other things going on. They could have heart disease, heart failure, totally could mimic COPD in a smoker. They could have anemia, and in fact, you can't forget the blood system when you think about shortness of breath, neuromuscular problems, and other lung problems. So what you see sort of here is that those are pulmonary arteries that are really thickened. People could have pulmonary hypertension. And you'll see a lot of that when you rotate at the U. Or here you see these are lungs with really thickened interstitium, and ILD would be a very common thing for people in their 60s with progressive shortness of breath on exertion to have. So many other things that they could have. And when you diagnose COPD, which by the way is defined currently very simply, persistent symptomatic airflow limitation due to airway and or alveolar abnormalities that is usually caused by significant exposure to noxious particles and gases, i.e. smoke, but other things that we inhale. And so you're going to look at patient risk factors. Do they smoke? What's their occupation? Are they exposed to indoor air pollution? Do they have a familial history of early onset COPD? And then you're going to look at their risk factors. You're going to look at their symptoms. And then you're going to look at spirometry, because without a low FEV1 VC ratio, forced expiratory volume in 1 second to forced vital capacity, you can't diagnose COPD. And again, you'll see that in the chart over and over again. You'll copy it in your H&Ps, you'll copy it in your clinic notes, patient with COPD. And if you go back and you dig, you can't find any PFTs, and you have to wonder, if they all have it. In your clinic, patients are going to present to you in 3 different ways with COPD. It'll either be previously diagnosed, either correctly diagnosed or incorrectly diagnosed, but it'll be previously diagnosed, or they'll have chronic symptoms, dyspnea, cough, whatever, and they'll complain to you, and you will work them up and diagnose COPD. But a lot of patients have very few complaints. As their lung function gets worse, they just sort of take on a greater sedentary lifestyle. They adapt to the symptoms they have and the limitations they have over time. And then all of a sudden, boom, they're in the hospital or your clinic with an acute exacerbation. And you're like, guess what? You have emphysema. And they're like, what? And so those are kinds of the 3 different ways that patients will present to you in clinic. And so don't be surprised if somebody finally gets diagnosed and has very advanced airflow obstruction on PFTs, but they don't complain very much. That's not an uncommon scenario. On physical exam, their exam can be, just like this guy, pretty normal. Yes, they can have decreased breath sounds, a few wheezes, a few crackles here and there, kind of not with any reproducible pattern, like in ILD necessarily, but sometimes you'll hear pulmonologists talk about just dirty lung sounds, a few rhonchi, a few crackles. They may be hyperinflated if you're good at detecting that, diaphragm's depressed with, percussion. If they're really sick, they may have that typical positioning where they sort of lean forward all the time, where they're using accessory muscles. They may have Hoover's and Dahl's signs or signs of cor pulmonale. Actually, anybody remember what Hoover's and Dahl's signs are, actually, since I threw them up on the slide? Hoover's sign is different than paradoxical respirations, but if you look at someone's chest with COPD, Hoover's sign is where the lateral walls of the chest move in with inspiration. Not paradoxical abdominal respiration, but actually where the lower lateral chest wall moves in. And the reason for that, I don't know if you can guess the reason for it, is if people are really hyperinflated, the diaphragm that's normally domed like this is hyperinflated and pushed flat. And so then when the diaphragm contracts, what does it do? It goes like that. And you see the lateral chest wall moving in. And so that's Hoover's sign. And then Dahl's sign is also called thinker's sign. And it's this, these pigmented, indented areas on the thigh, the middle thigh, from people leaning forward and leaning on their thighs for long periods of time during the day. So anyway, Hoover's sign and Dahl's sign, just kind of fun physical exam things. What about clubbing? What about clubbing? Is clubbing one of the physical exam findings of COPD?
No.
No. What do you worry about if a patient develops clubbing that you're caring for with COPD?
Squamous cell carcinoma.
Yeah, lung cancer, exactly. So, now clubbing is seen in one form of COPD that you'll get to know well at the U, and that's adult cystic fibrosis. People with cystic fibrosis have a different form of COPD, but they actually have marked clubbing. And people postulate all sorts of reasons for those differences. Anyway, chest X-ray. If you send your patient for a chest X-ray, it may very well look like this. There's sort of the upper lobe hyperlucency that you see. The cardiac shadow is usually very narrow. It sort of hangs down in the chest, unless they also have concomitant CHF and a dilated heart. But that's because the lungs are so hyperinflated, the heart's just hanging there in the middle. They're often hyperinflated, and their diaphragms are often very flat. So again, these are typical findings in a COPD X-ray. And in fact, the lateral is almost more impressive. You can really see how flat those diaphragms are. And the angle here is now greater than 90 degrees when normally should be less than 90 degrees. And this retrosternal airspace is expanded. So cool. So those are the chest X-rays. So then you're like, oh gosh, maybe this guy's got COPD. So you send him for PFTs. Here is PFTs. His FEV1 is 1.38. His ratio is 0.62. His TLC is 126% of predicted. His DLCO is 52% of predicted. Does he have does he have airflow obstruction? Right. Yes, he does. And because airflow obstruction is defined by this, you will see all these other things on PFTs. You'll see a low FEV1, but a low FEV1 by definition doesn't diagnose COPD. And we see that mistake being made in chest clinic all the time. Someone will get referred to chest clinic for difficult to manage COPD, getting worse, and they've had clinic spirometry that shows a low FEV1, but guess what? The vital capacity is also low, and they actually have restrictive lung disease, interstitial lung disease. So it's really the low ratio that is the sine qua non diagnostic hallmark. When you see our PFT reports and you see us calling hyperinflation, all that means is that there's a high total lung capacity. Whoops, sorry, I'm going the wrong direction. So this guy's total lung capacity was 126% of predicted. So we would say that, that he has hyperinflation. When you see us read air trapping, that means the residual volume is high in the lungs. Remember, the residual volume is the air left in the lung at the end of a maximal forced exhalation. And people who air trap can't get all the air out. They have that high residual volume. Patients with COPD may or may not have a bronchodilator response. And the way it's standardized is that the FEV1 has to increase by at least 12% in order to define a bronchodilator response. An 8% response just doesn't cut it, but it also has to be greater than 200 cc's, because you can imagine someone with a really low FEV1 could have a big percentage increase, but actually a very small absolute increase. So they have to have those two criteria. So as you read our reports, when you send patients, those are some of the things to sort of look for. So yes, he does have airflow obstruction. Now, the way we grade severity is through something called these gold stages, if you will, or grades of airflow obstruction. GOLD stands for the Global Initiative for Obstructive Lung Disease. The I is silent there. And it's they have a website, and you can find all this stuff on COPD patient education as well as provider education. But basically, if you have airflow obstruction, a low ratio, but your FEV1 is greater than 80% of predicted, that's pretty mild COPD, or mild airflow obstruction, I should say. And you can see the different grades. And so our guy actually had pretty severe airflow obstruction because his FEV1 was less than 49% of predicted. So actually pretty severe. But one of the things you'll notice as you care for these patients, if you haven't already noticed it from medical school and early R1 years, there's a really weak correlation between the severity of your FEV1, your symptoms, and your actual health impairment. I'm amazed sometimes at how someone with an FEV1 less than a liter, 0.88, sometimes is tootling around and doing just fine. And other people with an FEV1 twice that number just feel horrible, frequent exacerbations, they can't even walk around the supermarket. So it's really important to take health impairment into account when talking about caring for patients with COPD. And there are a whole bunch of different ways to get at symptom impairment. In the literature, there's the COPD assessment test. You can see the 5 different things that I just pulled from the literature. It doesn't really matter which one you use. This one is the MRC dyspnea scale. So the MRC, this is a British system where it's grade 0 through 4. I only get breathless with strenuous exercise to I'm too breathless to leave the house. And so you can do that. What we use more commonly in our system is the CAT, the COPD assessment test. And this is a picture of a pad of paper that many clinics have, where you can just give this to the patient and they can just score themselves. And there's different categories. I never cough, I cough all the time, and then you add up and you get a total score. Again, I don't think it matters what system your clinic uses, but I really would encourage you and your clinics to start taking into account one of these forms of assessing health impairment and not just airflow obstruction. And the reason is that we then factor all these things together into creating what's called the ABCD assessment of severity of COPD. And this is a complicated slide, actually, where, on the left-hand side, it starts with spirometrically confirmed diagnosis. And then you assess the airflow limitation. And that's the stages 1 through 4 based on FEV1. But then you look at 2 things: what their exacerbation history is, how frequently they have exacerbations, and then what's their assessment of their symptoms, for example, from the CAT, for example. And you put people into these 4 boxes. So like box A, for example, is a low symptom score and very few hospitalizations, and you can put people into different categories. So this guy has gold 3 FEV1, and then based on his symptom score and not having been hospitalized, just having sort of mild dyspnea on exertion, he would fall into gold category B in the ABCD category. So let's just talk through this a little bit more. Here's 2 patients. Both patients have a low FEV1. Both have similar CAT scores of 18. So they're both pretty symptomatic, modestly symptomatic. But one of them has had no exacerbations in the past year, and the other's had 3 exacerbations in the past year. So both would be labeled gold 4 in the old classification scheme, where we only take into account FEV1. but you know those two patients are different and may need different therapy. And so with the new scheme, this ABCD scheme, the subject with the 3 exacerbations would be labeled as stage 4 group D. The other would be stage or grade 4 group B. And so that's how you use this. And the reason is that our therapies are going to be different. And that's the reason to be thinking about how to classify your patients. Now, if we could create sort of an ideal drug for COPD or ideal group of drugs, they would help us reduce symptoms, right? That makes sense. We want to control symptoms. And we would try to reduce their risk of future problems, either by preventing progression of the disease, literally preventing the continued fall of FEV1, or preventing and treating exacerbations, or reducing mortality. Those would be our ideal goals of treatment. So another poll question: which of the following therapies reduces progression of disease? That is, slows the rate of loss of lung function. Advair, Spiriva, smoking cessation, pulmonary rehab, or prednisone, oral corticosteroids. Come on, you guys, it's got to be Advair. Have you seen those ads on TV? People are like, you know, skating through the park.
They're so happy.
They are so happy on Advair. Oh my God, at least the company's happy that they're using Advair. So, but you're totally right. The only thing, none of the drugs that we have slow down the rate of loss of lung function. There was some initial hope that tiotropium actually might do that. But then in clinical trials, because it did it in some animal models, but in clinical trials, it didn't play out. The only thing is smoking cessation. Exactly right. Okay, another question. Which of the following then reduces mortality? So now we know we can't change the slope, but which one of these therapies reduces mortality in patients with COPD? Yeah, this one's a harder question, isn't it? The drug companies would be happy with 2 of you. I love that you picked pulmonary rehab. We're going to talk about pulmonary rehab a little bit later. But pulmonary rehab improves quality of life, but it doesn't change mortality. It's really only long-term oxygen therapy in people who qualify for it that has been shown to change mortality, not Advair, not TO, not any of all these newfangled drugs. So we're not doing so well on our ideal treatment yet. And then, so yeah, long-term oxygen therapy. Okay, now I already gave you a little bit of a clue here. Which of the following therapies improve morbidity and quality of life in COPD? Advair, Spiriva, pulmonary rehab, long-term oxygen therapy, prednisone, antidepressants. Let me ask you yeah, good. Let me ask you a parallel question. Pulmonary rehab absolutely does. Do any of the others? do you think?
Probably they all do.
Yeah, I'll give you a hint. They all do except one. Which one do you think it might be?
Prednisone?
Yeah, good. Prednisone. Prednisone is the only thing on this list that actually worsens patients' quality of life. Everything else actually, so Advair and Spiriva have been shown to improve morbidity. Pulmonary rehab improves quality of life. Long-term oxygen therapy improves morbidity, and antidepressants improves morbidity and quality of life. Totally. So it's all of them but prednisone. So let's move forward then and try to figure out then how to approach initial and subsequent pharmacological therapy. What you see on this slide are the four groups, if you will. The poll just popped back up on me. How do I close that? There we go. So again, what you see is symptoms on the top, low symptom score, high symptom score, frequent exacerbations, infrequent exacerbations, and then the group A, B, C, D. Oh, what happened? Pushing the wrong buttons on this thing. So group A, infrequent exacerbations and very mildly symptomatic, you're just going to start with a PRN bronchodilator, short-acting beta agonist, SABA, or short-acting antimuscarinic agent, SAMA, SABA and SAMA. If they have group B, so infrequent exacerbations, but they have much more symptoms, you use a long-acting bronchodilator, long-acting beta agonist, or LAMA, long-acting antimuscarinic. In group C, where they have more exacerbations, but they're mildly symptomatic, there's actually data not to start with either, as in group B, but to actually start with the long-acting antimuscarinic, like Spiriva. But there's other brands as well. And that's been shown to be a better place to start. And then in the highly symptomatic people with lots of exacerbations, high risk, highly symptomatic, you're going to have a long-acting antimuscarinic, a long-acting beta agonist combined, or you're going to start with a long-acting beta agonist and an inhaled corticosteroid. And brand new data that I'll share with you in a moment, especially if they have a high peripheral eosinophil count. So group A, B, C, D for initial pharmacologic treatment. Yeah, so that's how you use the table. And then the goal is you escalate, rather than throwing the kitchen sink at them right from the start, you escalate then when you have uncontrolled symptoms or increasing exacerbations. So if you've started with a LABA or LAMA, and they still have exacerbations, you can either do the combo, or you can put the LABA with an inhaled corticosteroid, ICS inhaled corticosteroid. And again, that asterisk is especially if they have high eosinophils. If they have low eosinophils, you might start over here. And then if they continue to have more symptoms, if their eosinophil count is elevated at 100 now instead of 300, you'll add the third agent. You'll give them triple therapy. If they have a low eosinophil count, you may add roflumilast or azithromycin. Once patients wind up on inhaled corticosteroids, there's also new data about de-escalating whenever possible. And we'll talk a little bit more about that. So that's sort of the rubric for starting and then escalating in the setting of uncontrolled symptoms or frequent hospitalizations. The eosinophil data is fascinating. It's brand new. It's really just evolving. And I, in truth be told, I haven't completely put this into play in my clinic yet, but I'm trying to get some experience with it. But these are data from just last year in 2019. And in the graph on the left, you see all patients, and it was close to close to 10,000 patients in this IMPACT trial, which was a trial of triple therapy versus double therapy. And so they did this analysis of the trial, and you can see on the left-hand side that baseline eosinophil count was low in the vast majority of patients, and it was high only in a smaller subset of patients. But over here, you see the annual exacerbation rate and baseline eosinophil count. And the green group of patients were the only patients who didn't get inhaled corticosteroids. So at low eosinophil counts, there was very equal rates of exacerbation regardless of therapy. But in patients who had higher eosinophil counts, if they were on an inhaled steroid, they didn't have those exacerbations where those people did. So kind of some really interesting data that's evolving, looking at peripheral eosinophil counts, not sputum, but peripheral eosinophil counts in patients with COPD. With regards to which inhaled steroid or which inhaler, this is actually a picture from our own clinic, chest clinic at Harborview. We have this, because I can't keep track of, these are like cephalosporins. I can't keep track of all the new inhalers that are coming out left and right. But hopefully you'll have a table like this in your clinic. And my point is that each of those bars is anticholinergics, combination, inhaled corticosteroids, short acting, long acting. The point is that within a class of drug with inhaled corticosteroid, long acting antimuscarinics, the drug companies would have you believe differently, but there really is no significant difference one to the other. I don't really care which inhaled corticosteroid you prescribe to your patients if they have advanced COPD and have a high eosinophil count. It's going to be driven by cost and by insurance plan. The insurance plans tell you often which ones you can use. It may be driven by patient preference. Oh yeah, I like umaclidine, but I don't like tiotropium because the taste is a little bit different. And there are some adverse effects that are different between them. But don't stress too much about, is Advair better than Brio Ellipta? Oh, for God's sakes. You get my point. So don't stress too much about that. A few other words about inhaled corticosteroids, because we use them all the time. Think about your patients who are on, inhaled fluticasone for COPD. Just to remind you what we've talked about so far, there is no effect on mortality and no effect on decline over time in lung function. They don't prevent things from getting worse. They do decrease the number of exacerbations patients have. They improve their symptoms. They have better health status. Their symptoms are slower to progress, but actually if you're measuring PFTs, their lung function is not slower to progress. And another caveat, unlike asthma, don't use corticosteroid monotherapy in COPD. Instead, only use in combination with other bronchodilators, because that could run into trouble in your patients with COPD. They need the other bronchodilators as well. Now, one last thing about inhaled steroids, the Wisdom trial, which now is 5-6 years old, was a study in the New England Journal of withdrawing inhaled corticosteroids in people who are already on them. And what you can see in this panel on the left over here is this is weeks up to a year, and the probability on the y-axis. And the two bars are the group that had inhaled glucocorticoids withdrawn versus those who are continued. And there was no difference at all in patients who had probability of an exacerbation. So these are now people who were stable on inhaled corticosteroids. The panel on the right side is kind of interesting. Here you see change in FEV1 and weak over here, and the groups that had the fluticasone reduced to 500, 200, and 0. And those who basically stayed on the inhaled steroids had no change in their FEV1. Those on fluticasone on lower doses, as the dose was dropped, they had incremental declinations in their FEV1. But as we showed over here, no change in their exacerbation rate. And so the way I'm implementing this is if I've had someone who's had bad COPD and we've escalated to inhaled corticosteroids and now they're stable, if they're relatively stable after a period of 3 to 6 months on that, then I will start to de-escalate their inhaled corticosteroids. I might decrease the dose and then try to get them off it completely. Does that make sense? And that's also that de-escalation and the use of eosinophils are two of the newer things in managing patients with COPD. Now, just a word or two on long-term oxygen therapy. These are the criteria that are in place for insurance companies to approve home oxygen. You have to have a PaO2 of less than or equal to 55 or a SAT less than or equal to 88. And the rules say either at rest or with exercise. So here's what I do in clinic. If I've got someone whose SATs are 90 at rest, but I really feel they would benefit from home oxygen, I put a pulse oximeter on them and I walk them in a loop around clinic and they drop their SAT to 86 or 87%. Boom, they qualify for home oxygen. So don't forget to do exercise oximetry if you really want to get your patients home oxygen. Home oxygen does improve survival. These are composite data from 2 different trials, the Nocturnal Oxygen Treatment Trial and the Medical Research Council trial in England of continuous and nocturnal oxygen. And the point I want to make here is that after 3 years, here's the survival curve. First of all, look at the overall survival curve. People who qualify for home oxygen, almost half of them will die within 3 years. But if you're not using any oxygen, it's a 40% survival rate. And if you're using home oxygen, it's a 55 to 60% survival rate. And look at this, even if you only use oxygen at night, like if you have a patient who says, I hate wearing my oxygen when I go to the supermarket, but they're willing to wear it at home or at night, that still helps them. It still is beneficial, not as beneficial as 24-hour oxygen. So, so I try to get them, I don't stress when I first start somebody on it. I just wear this as much as you can for now, you know, kind of a thing, and they will benefit from it. Switching gears a little bit more too, putting your general internist hat on, COPD really is a systemic disease, and you really have to think about the extrapulmonary manifestations of COPD. Yes, they have tons of respiratory symptoms, but they will often lose weight. There's sort of that COPD cachexia as people get. In fact, that's a really bad sign. You have somebody with emphysema and now they start losing weight because so much of their energy consumption is just for breathing. that's a really bad sign that they're entering late stages. Skeletal muscle wasting. Osteoporosis is huge and is independent of the use of steroids, inhaled or oral steroids. So these patients should be screened for osteoporosis. The rate of depression, I had that question about antidepressants on that earlier slide. The rate of depression in these folks is something like 30 or 40%. And not just sort of the usual blues about, oh, I just can't get out and do as much and woe is me, but true major depression. And it can be unrecognized because, again, their lives become more sedentary, and we think, oh, it makes, or their families think it makes sense that they're sad now, they're on oxygen at home, but treating depression really improves things for them. They tend to be anemic. They have an increased risk of cardiovascular disease. There's that COPD CHF, just kind of runs together as a single diagnosis sometimes. And they do have systemic inflammation that does lead to an acceleration of atherosclerosis and cardiovascular disease. So you have to be looking for that in your patients. We touched on pulmonary rehab, and pulmonary rehab helps address many of those things on that previous slide. It's really a multidisciplinary program where they give them education and they train them to how to exercise properly, how to breathe properly, how to use their inhalers. That's something we do really poorly in our clinics. We give them the inhalers and then we think, oh, it should be intuitive that they know how to use these things. But they do a lot of that in pulmonary rehab classes, nutritional therapy, behavioral and psychosocial interventions. It helps with long-term adherence. It helps with quality of life. And I think anybody, and by the way, this is another, our healthcare system is just so messed up. But of all the things we do for patients with COPD, pulmonary rehab, there's study after study after study that we get improved outcomes with pulmonary rehab. Do insurance companies pay for it? No, many don't. It's just tragic. And so then this is another healthcare disparity. People who can afford it pay for it themselves, and people who can't afford it, their insurance won't cover it. And yet this is one of the things that makes a difference. Your clinics know the access to pulmonary rehab. Different clinics, like the VA has their own program. There are a couple of private programs around town that accept public insurance. And so talk to your clinic managers and your clinic chiefs to find out about the best way to get your people into pulmonary rehab. And it, as I said, it does all these fantastic things for people, and it's evidence-based. Kind of winding things up, when to actually send your patients to me. And I have a strong bias. I think that the vast majority, I don't know, some huge number, 90%, let's say, 85%, 90% of patients with COPD can be managed by a general internist, because you're going to pay more attention to those other factors that are really important. And quite honestly, there's not a ton of things that we can do with the exception of a few advanced new therapies. So just because your patient has severe COPD does not necessarily warrant a referral to chest clinic. But if it's a confusing picture, alpha-1 antitrypsin was brought up earlier, that requires very specialized treatment. Screening people for sort of atypical forms of cystic fibrosis, if they have rapidly progressive or precocious emphysema, or if it's occupationally induced. It's not that the treatment is different for occupational lung disease. It's that chest clinics and pulmonologists often have systems in place. The paperwork to go along with filing things for patients with occupational lung disease can be daunting, and chest clinics often have streamlined ways to deal with that. Or if you're having trouble managing the disease, really frequent exacerbations, symptoms out of proportion to spirometry, chronic oral steroids, those are reasons to refer. And then if you're really thinking, I wonder if this person would benefit from surgery, either lung volume reduction surgery or lung transplant, or if some of these newer medications, azithromycin, chronic azithromycin, or roflumilast might be beneficial. Those are times, but again, 90% of your patients don't need to be referred to me. And when they are referred to me, we often find other things. That's where we turn up interstitial lung disease, either instead of or on top of COPD, or we discover they have pretty advanced pulmonary hypertension and need pulmonary hypertension meds on top of their COPD meds. So yeah, that's when to refer. Finally, just wrapping up, I learned this trick about 2 years ago from fellows in our clinic. In Epic, they create a little template for managing, patients with COPD. And I think these are really good tips so that you at a glance can just see where your patient is on the trajectory of care. So your little hashtag COPD, and again, you can create it as a dot phrase. You want to know the last exacerbation, because now how frequent their exacerbations are is important. Their last FEV1, you do not have to do annual spirometry for these folks, but knowing when their last FEV1 was. Their maintenance regimen, are they on home oxygen? Do they have sleep disordered breathing? Pulmonary rehab, vaccinations, and low-dose CT screening. And so if you create these headings in your chart note, then it's very easy to just go and fill them out. And so it might look something like this. This was one patient from Chest Clinic, last exacerbation, nearly continuous exacerbations, last FEV1, 0.89 in 2013, the maintenance regimen, the home oxygen, known severe OSA, considering a trial of BiPAP, declined pulmonary rehab, their vaccinations, and then their CT screening. So just a helpful way to keep track of some of these folks. So in summary, overall key points, COPD really does disproportionately impact disadvantaged patients. And I want you to be keeping that in mind as you care for them. Don't diagnose COPD without PFTs. And then individualize your management for patients with stable COPD based on their assessment of their symptoms and their risk for exacerbations, the ABCD quadrant. Everyone who smokes should be strongly encouraged to quit. I think you had another talk on smoking cessation during the immersion block. And then again, main treatment goals, reduce symptoms, reduce future risk. New stuff, consider eosinophil count when prescribing inhaled corticosteroids. Your attendings are not even going to know about this. So it'll be cool when you start bringing it up with them. And then screen for the systemic complications that go along with COPD. A hip fracture from osteoporosis will be devastating to someone who already has advanced lung disease. And if you can prevent that, you're doing way better than trying to decide between, two different long-acting inhalers for them. And then again, the non-pharmacologic interventions are super important. So with that, I will close. I couldn't cover many of these other important aspects of caring for people with COPD, including, very importantly, end-of-life care, by the way. This is the time to be talking to people with advanced COPD is in clinic, not when they arrive in the ER short of breath and you ask them, do you want everything done? And they go, of course I do, doc. But I don't, anyway, those are future topics. So with that, I will close with my favorite Marlboro ad. We have just a minute or two to sort of answer any questions that you might have. Cool. And I don't know whether you guys are using the chat box or you just want to, yeah, prednisone for a boost of energy. Exactly. Hey, you changed your background, Mac.
I did.
You went
It morphs throughout the talks usually.
Yeah, well, I noticed you went from water to mountains, so.
Yeah.
Yeah, cool.
It's actually called a Mac ground.
Oh, God.
Sorry.
Okay, that one I don't like. There you go. Now you're talking. Questions, you guys? Helpful at all? Yeah, it's just a framework, big overview framework. Yeah, so. All right, lunchtime.